The Georgia Legislative Black Caucus is 61 members strong. That's in the House and Senate. We are the largest black caucus in the nation. And we know how important the issue of HIV/AIDS and in particular, and the other STDs are to the African American population here in the state of Georgia. We know that we have alarming numbers, and we're so glad that you came out today to have this hearing with us so that we can find ways to tackle this epidemic. And so we are very appreciative of that. Senator Vincent Ford is actually the moderator. He is en route, but we do have another Black Caucus member who is here right now. I'm going to allow her to introduce herself until the other members come into the room.
Good afternoon.
Which number are you?
Good afternoon. My name is Kimberly Alexander, and I represent Douglas County and Paulding County, and that's District 66. Welcome.
Thank you, Representative Alexander. Okay, so this is how we're going to get started, because I believe it's starting on time, so I'm just going to fill in for Senator Ford until he gets here. How about that? That's why I'm here. So let me introduce myself. My name is Representative D. Dawkins Hagler. I am the chair of the Georgia Legislative Black Caucus, and I represent House District 91, which is DeKalb and Rockdale counties. And so let me tell you a little bit about how we got started and got to this place. 2 years ago, Devin Ward came to me and said, I would like to do something for World AIDS Day. And I said, well, that's a great idea, Devin. And so in December of 2013, we had our first symposium on world dealing with HIV and AIDS. Devin came back the next year and said, well, because that was successful, I want to do it a little bigger, even better. So he came up with this idea to do it once again. And so last year, December in 2014, the Black Caucus took that task on again to have another symposium dealing with HIV/AIDS, but this time including other STDs. And so after listening through the symposium, we thought it was very salient that we would have here at the Capitol an actual hearing so that we could have it on record of what's going on in the state of Georgia, not just a symposium, but to come and get recommendations of how we can craft some legislation that could deal with this issue in the state of Georgia and how we would go forward tackling it. And so that is how we got to this place. And so I do want to thank Devin, even though he's not in the room yet, for his foresight and all of this. He has been I don't know if you all know this, but he started his career at the General Assembly working for Senator Ronald Ramsey and then Representative Keisha Waits. And he even worked on one of my campaigns in the very beginning. So Devin is very active. He's an activist in this issue, and so even though he's in D.C. working hard, and he's outside in the hall. And Devin, I was talking about you real good. Y'all, didn't I give Devin a good I really did talk about you very well. I told him how all of this got started, how you was the brainchild from 2013 to 2014 to now we're here. So there we are. And so that is how we got to this place. And so I told y'all, because I always start on time, and I've done all the particulars. The moderator is now here. We was going to have two moderators, Representative Keisha Waits and Senator Ford, so we're going to try to tag team this, but Senator Ford is going to lead the way, and we're just so glad that you all are here, that you all have all answered the role. I know who all is present in the room. We have a lot of speakers, invited guests, and we have a lot of public testimonials. And so Representative Smith, before we start, come up here and come sit down and introduce yourself to all the people. Thank you, sir. And then tell me what mic you're going to be.
All righty, 12. I'm Representative Ernie Smith, District 125 out of Augusta, Georgia. Glad to be here today.
Thank you so much. Can anyone tell me if Michelle Allen has arrived yet?
She's here. She's coming.
She is here. Okay. And what about and so everybody's here. Okay. So everybody's here. Okay. Thank you. I'm turning it over now to Senator Vincent Ford.
Good afternoon.
Good afternoon.
No, I just got here. You can't be mad at me.
Good afternoon.
Good afternoon.
Good afternoon.
All right. Now I know I'm with folk who have some energy. My name is Vincent Ford. I serve the 39th Senatorial District, which is Atlanta, East Point, College Park, Union City. and unincorporated Fulton County. I'm glad to be here. We had the Georgia Legislative Black Caucus has taken on the issue of Georgia's HIV epidemic, has taken it on as a priority issue. And I want to once again thank our chair, Dee Dawkins-Hagler, for the leadership she has provided on this issue. And I want to give her a round of applause. She said I was so kind, but we're going to recognize those who think it not robbery to stand up for people who oftentimes cannot stand up for themselves. So we appreciate it very much. But I did say that the Black Caucus is taking on this issue as a priority. It is an issue whose time has come for the Black Caucus. We can no longer have activity on this issue be at a minimum. We need to maximize our commitment to this issue. And as one Black Caucus member, that's what I am committed to because the HIV epidemic, from what the experts tell me, from what some of the panelists tell me, is the HIV epidemic is ground zero in many districts that the Black Caucus represents. I'm told that my district, which goes from Buckhead to Bankhead to Union City, is in fact one of those districts where the HIV epidemic is really ground zero. So we hear about serious business. I just want to reflect very quickly. Over the last few weeks, we have seen a lot of information. What public health story has been on the news in the last several weeks? Measles and vaccination. And that's all well and good, and we appreciate that. But public awareness is critical in public health. Public awareness is critical. So the business that we're doing this afternoon, absolutely important, cannot be ignored. And I appreciate all of you for thinking it not robbery to be here with us this afternoon. What I'm going to do before we start introducing people and asking people to speak, I'm going to ask Black Caucus members who are here to introduce themselves. One of our members has introduced themselves. Representative Alexander, you've introduced yourself. Is that correct? Yes. Okay, I'm going to ask Senator James and Representative Scott, beginning with Senator James, to introduce yourself, your district, and where it's located.
Thank you, Senator Forts. Hello?
What number is Donna?
I'm number 25. Okay, that's it. Good evening. I'm Senator Gonzalo James of the 35th Senate District, and welcome to the Capitol. Look forward to hearing from you.
Good afternoon. I'm State Representative Sandra G. Scott from Clayton and Henry County, District 76.
All right, Representative Anderson, can you introduce yourself?
Greetings, everyone. My name is Representative Tanya Anderson, District 92, which covers DeKalb and Rockdale County.
All right, I appreciate her not even needing a microphone.
That's right.
I appreciate that. All right. What we're going to do, and I want to recognize my good friend, Commissioner Joan Garner, Fulton County. Can you stand and let folks see you? And our districts do overlap.
Yes.
And so we're kind of partners in crime here in Fulton County. We appreciate you being here. I am going to ask Mr. Lyon, and if I mispronounce anybody's name this afternoon, assign it to my head, not to my heart, okay? I'm going to ask William Lyons, HIV Director of Georgia Department of Public Health, to come to make his presentation.
I'm here.
And well, how long is your presentation going to be?
We were told we had 15 minutes between me and Michelle, so we'll condense it to that.
All right, we're going to time you accordingly, 15 minutes.
Good afternoon. I don't think the mic is on, but hopefully y'all can hear me. So we're going to start today. My name is William Lyons. I'm the Director of HIV and AIDS at the Department of Public Health. We're just going to run quickly through a couple of epi slides. Most of the people in the room know about the disparity among African Americans, but we just wanted to show you a couple of slides. The first slide shows how many people are living with HIV and AIDS in the state of Georgia, over 51,000. And as you can see on the large pie chart, 66% of those are black. In the smaller pie chart, you can see that 67% of the new diagnoses among African Americans. Here, this just shows the disparity between the races, 6 times higher among blacks with the HIV prevalence rate. Here we have the new diagnosis disparity is 8.2 times higher than whites in the state of Georgia. This is a brief slide from a study that was done, and unfortunately, this shows the disparity among young black MSM. As you see, from the age of 18 to 19, from the age of 30 to 39, it shows you that it's an estimate of 60% of them may have contracted HIV by that age. This slide is a part of the care continuum, where you see the red circles. That basically shows the viral load suppression. That means that the viral load is in your body is low and undetectable. So you see here, once again, there is still a disparity with African Americans, blacks, being the lowest viral suppression. We're going to go a little bit into what the prevention unit is doing. Our goals are aligned with the National HIV and AIDS strategies to reduce HIV infections, increase access to care for all, and reduce HIV-related health disparities among minorities. Here we have the number of testing events that were done in 2013. 71,000 of those 86 were actually rapid tests, which are 15 to 20-minute tests that detect HIV. We had, in the public health system, we had 278 diagnosed, and the previous of those were 77. Here, this is a breakdown between gender and risk. As you see here, males make up the most of the group with 78% of those diagnosed in 2013. And in the risk category in the blue, where it says 56%, that's MSM, men having sex with men. Once again, a slide that shows you the disparity in the race with the number of new positives that were 80% were African American. This is one of the grants we had from the feds. There was only 8 states awarded the Care and Prevention United States Demonstration Project. We're very proud to have that grant. There were only 8 states that were awarded. And this is a grant that is used to strengthen systems in the states that got the funds. And so some of the things that we're doing with that grant is a testing and linkage consortium, which meets annually to coordinate calendars. An anti-stigma campaign, particularly among young African Americans that are targeted with the anti-stigma campaign. Grant aids that go to the districts, resource hub. We're also giving some funding to corrections to do testing and linkage. In 2014, we gave over 1.2 million condoms throughout the state of Georgia. 70% of the prevention funds were awarded to minority organizations. Health districts and community-based organizations received more than 60,000 items, promotional items, condoms, and the like to give out to the general public. And we spent $225,000 on our minority-focused media campaign. That campaign is called Greater Than AIDS. It's a partnership with the Kaiser Foundation. We had 11.8 million media impressions, 137,000 video views, 358 indoor PSAs targeted at LGBT-friendly businesses. And we also launched a Speak Out campaign, which is a campaign for young MSM. We yearly have a MSM symposium. We're proud to say that this will be the 4th year that we've had this symposium. Last year we had 300 participants, and it focuses on health issues, social determinants, community concerns, stigma among the MSM community in the state of Georgia. We're going to go a couple of slides with HIV care, and that's the patient care. So that's your AIDS drug assistance program and your medical visits, where people who have HIV and AIDS are able to attain medical care in Ryan White clinics. The first one is an additional grant that we have called the Minority AIDS Initiative, and that grant seeks to link people who have been out of care back into care using a small amount of HIV dollars to link them back into the AIDS Drug Assistance Program. And that program is particularly only for minorities. This slide shows the AIDS Drug Assistance Program. Out of all the clients that we serve, you see here that 69% are actually African American, and the AIDS Drug Assistance Program covers the entire state of Georgia. Ryan White Client Services, these are the people who come into our Ryan White clinics, which are throughout the districts, and you can see here that 71% of those clients are African American. And so that ran through mine pretty quickly because I want Michelle to be able to get through hers. We hold questions till the end?
Yeah, after the presentation. Yeah.
Okay, thank you.
So while we're changing slides, I'd like to go ahead and introduce myself so that we can move fast. My name is Michelle Allen. I'm from the Georgia Department of Public Health, where I serve as the State STD Director. I have a green ribbon on my lapel. Please always remember this ribbon. When you see the pink ribbon, you think about breast cancer and being a survivor. I have been asked before, I'm actually not an STD survivor, but the ribbon is important just the same. Somebody said, did you fight gonorrhea and win? No, but I'm proud to be here. I'm passing out the ribbon so you can wear it and you know every time you see it what it's about. STD prevention is HIV prevention. STD Awareness Month is in April. Always remember that. So I'm very thankful to come with William because STD and HIV work very closely together, and because I know you get invited back if you honor the time you've been given.
Amen.
Absolutely.
Peace and love to everyone. While they give me slides ready, I want to introduce myself. I'm Abel Mabel Thomas, State Representative, District 56, and my area covers Atlanta, Fulton County, Ansley Park, Midtown, Atlantic Station, Bankhead, East Chatham, Bryan City, West End, Westview, Dixie Hill, Martin Luther King, Benjamin Bay. And I'm glad to be here, and I want to give a shout out to my good friend Trevor Pearson. All right, and also my good friend Dazon Dixon Diallo. I've been knowing her for a long time, so Dazon, I'm giving you a shout out.
We love you back.
Okay, thank you. All right. County Commissioner, for the County Commissioner, John Gardner, thank you. There's other people I know, but what can I say?
I'm State Senator Gail Davenport, represent Senate District 44, portions of Clayton County and portions of DeKalb County. Glad to have you all here today.
Okay, thank you. I'd like to draw your attention to this slide that I pray becomes a billboard. If I did not have enough money to change this out from 3 years ago, the fact that we were #1 in syphilis would still hold true. One thing that we see in Georgia is that usually our infectious cases of syphilis are also co-infected with HIV. Hence, STD prevention is HIV prevention. Also, draw your attention to the fact that those are top 10 rankings. #1, 6, 8, 9. That's congenital syphilis. So as we think about perinatal transmission, we don't want to forget syphilis cases. We don't want to forget hepatitis cases. We also want to think about gonorrhea and chlamydia. So those syphilis, gonorrhea, and chlamydia are bacteria, easily treated, easily cured. These are winnable battles for us to address. When you look at age group, if I draw your attention from 15 to 29, those are the groups that you are usually concerned about when you think about STDs overall. You say, okay, what's going on with young people? But you will see as we move through the slide that syphilis can sometimes bring a little mature crowd into the fold. Wow. Okay, This slide is very important because that blue bar represents unknown race or ethnicity. Reporting laws are on the book, but oftentimes case reports and labs are incomplete with very important vital demographic information missing. We do a wonderful job with syphilis, and so we have less missing demographic information in those areas. With gonorrhea committee and syphilis together, independent of HIV, we bring about 60,000 cases every single year. So that's a lot of critical information that we could really benefit from. Okay, so let's look at gender. And you see female, and I know you're thinking, what is going on with the blue bar? Chlamydia is the disease of choice nationwide and also here in Georgia. We have a lot of chlamydia. Screening, targeting for women is very aggressive. You usually see in either women's health or family planning clinics a lot of screening. And so the overrepresentation for female is usually attributed to chlamydia. So I want to talk about syphilis just a little bit longer. When you look at that first bullet, it very clearly demonstrates that we have a problem among African American men. And William talked earlier saying men who have sex with men. We are co-chairs with the symposium efforts that go on in our department, and we also have a national presence where we're sitting on MSM work groups. I'm proud to say that in the area of sexual health, the Georgia Department of Public Health, STD, HIV office, we are players at national tables. So when you're number one, what does that mean? We're number one in the country, but if you look down, DeKalb County, Cobb, Clayton, and Gwinnett all rank nationally by themselves. The syphilis problem is very contained, and only about 80 counties nationally report the morbidity for the entire country. So to be 59th in Georgia would be pretty heavy with 159 counties. But let's be clear, we're looking at 59th nationwide. Syphilis cases in this data does not include congenital. You see that arrow from 2012 to 2013? It indicates an increase. This is not something that just happened exclusively in the state of Georgia. It's also something that happened around the country. So a lot of times people go, what is going on? Traditional STD efforts of assuming that all patients knowing their sex partners no longer exist. Sometimes people have sex using venues or applications where they purposefully do not know the person they're having sex with. So in those cases, traditional tactics do not work. You have to try institutional screenings and partnerships. You're out in the clubs, you're out with your community-based organizations, which I'm happy to say are well represented on these first few pews. Okay, so when we look at ethnicity, again, pointing out the glaring disparity of the green bar from the rest of the bars that you see. The green bar, like my ribbon, is representing syphilis, and here the green bar is representing Black non-Hispanic males. So I'm going to move on a little bit, but I want to make the point so you can see when you look at 2009 to 2013, and you see that blue bar, again, we have a overrepresentation, a huge burden, very well represented in our data for blacks. Congenital syphilis. Now, of all syphilis, this breaks my heart. Congenital syphilis is a winnable battle. We certainly can say that congenital syphilis is preventable. I told you earlier that syphilis is treatable, so what's going on? Obviously, we want to make sure that pregnant women are being screened for syphilis. We not only want to make sure that they're being screened for HIV, but also include syphilis. We also have a difficult time with missing information. And so that is very critical. If a child is born, a lab slip may say baby girl such and such, and that doesn't help you find a child. So in the STD program, in addition to working with our partners in HIV, we also have to work with our partners in information, in immunization, because GRITS data also has vital information on children. And that GRITS is the Georgia Registry for Immunizations. So let's talk about this disease of choice a little bit. Nationally, chlamydia dropped, and we are not sure what that is attributable to. We don't know if it's less encounters in public health. We don't know if policies in some areas have affected it, because we do have expedited partner therapy and partner delivered therapy going around in different places around the country. But one thing we know for sure is that everyone across the country dropped, including Georgia. When we look at cases by gender, this is no surprise, and it ties into the slide I showed you earlier. Women being overrepresented does not surprise me. Women are often screened for chlamydia in family planning or women's health settings, and so that makes a lot of sense in terms of data. What is a little bit tough and what's noteworthy to mention is chlamydia is typically asymptomatic. So a male in care may not ask for a test because he's not aware of the symptoms. So this is why teaming up with community-based agencies and working in non-traditional venues is very important, so you can bring the test to the population that needs to be tested. So let's talk about gonorrhea. Gonorrhea did decrease overall in the U.S. Again, we still have a top 10 ranking. If I can draw your attention to that last bullet, Fulton County and DeKalb County jump up and rank nationally. So notice how every time I talked about a national ranking, you have heard Fulton and DeKalb counties. We're looking at the blue bar, and based on everything that I have told you, as you look at the dark blue bar, what do you think that is? You are correct, it is still African Americans. So I would like to close by saying, when you see those numbers, it begs the question, what in the world are you all doing? 159 counties have 159 boards of health. I'm proud to say that we support testing in over 400 counties in our state. That includes working with the Department of Juvenile Justice. That includes working with colleges and universities. We also provide the medicine that's needed using a mission-critical 340B discount from HRSA. We also go out and respond to outbreaks. So we know that there is work to be done, but I thought it fitting to end on a high note that there's work to be done, and you have people that are willing to do the work. Thank you so much for your time.
To the microphone to present. One of the things that we want to keep in mind is that the Legislative Black Caucus is just that. We are legislators, and we legislate. We pass laws to determine policy. So I would hope that each person who steps to the microphone comes with a policy change that can be done by legislation. We're not here only to hear you. We want to hear you and then put what you say into some legislative form so we can help the situation. So please keep that in mind as we move forward during the day, because we're going to have an opportunity to ask some questions. I'm going to ask Amistad Adolf St. Rahman to come to the microphone. He is the Executive Director of the National Aid Education Services for Minorities. We're going to give you, at this point, we're going to ask speakers to come forward for 5 minutes and present 5 minutes. We've got a long list of people, as well as a lot of public. We have about 15 people who want to give public testimonials. You will have an opportunity during question and answer to speak to other points, but we're going to ask you at this point to try to hold your presentation to 5 to 6 minutes.
Okay, thank you. Well, good afternoon, everyone. I want to thank the body for having this really wonderful meeting this afternoon. I think that it's about time that our state of Georgia and our city of Atlanta, it's about time that we started having conversations about this very real, this very public issue that is happening around HIV. Given my 5 minutes, I actually had a different type of speech I was going to give, but since I only have 5 minutes, I'm just going to keep it cute since we're all a family, we're all here together. And the people on this side of the seats, I pretty much know a whole bunch of people, so I don't have to go through all the epidemiology and stuff. So I wanted to start off as a person living with HIV. If I were living with HIV, and I'm living with HIV today in Georgia, and what are my needs? So my number one thing that I want to say is that if most people that we are working with in our community living with HIV, when they don't have obviously health insurance, that seems to be a priority for us. And I know that the Legislative Caucus is doing its own thing, and I know that our state of Georgia, they're doing their thing. But obviously, first and foremost, making sure that people have access to quality health insurance, which would reduce some disparities, would go a long way. So that's the first thing. But in lieu of not having access to health insurance, what would I want you as people who make laws to know about people like me? First, I would want you to know that a person like me, just because I'm living with HIV, does not make me a criminal. Currently on the books today, a person like me, if I were to go out today and have sex with someone without telling them my status, I'm liable to go to jail. This has some significant implications for public health and the work that we are all interested in. Because as William earlier had talked about, and as many of you know, HIV stigma is a factor that drives HIV not only in this country, but in our community. And so having the stigma of HIV and having met a partner and having to tell that person that day, that minute, that second that I'm HIV positive is a barrier could be potentially a barrier for people living with HIV. As a result of that, most people don't tell their HIV statuses. And so what we have today is a bunch of people who are living with HIV, who are HIV positive, that are fearful of telling their HIV statuses. And when they don't tell, obviously, by law, they're labeled as criminals. So living with HIV doesn't make me a criminal, it just makes me a person living with HIV. So the first thing that I would like for you to consider, if you considered everything, and the second thing really would be to let's have conversations with ourselves about how do we decriminalize people like me living with HIV. Me telling my HIV status is not something that's always comfortable or easy to do. Although I've lived with HIV for 25 years, it is not something that I always want to do. It's not every restaurant, it's not every movie theater that's suitable for me to tell somebody brand new about my HIV status. So that's one of the policies that I want us to consider as we take on this challenge of figuring out how do we address HIV in our community. So that would be one. Secondly, you'll hear more about it later on, but there's a significant amount of money and dollars that are here on the streets that we could be using currently as taxpayers. They're not really being used in the way that we ought to be using them. And later on, I'm sure that there will be other people who talk about how HIV funding is allocated here in our city and in our state. So the other issue that I would like to bring up is that just how we allocate funding, how funding comes down to community-based organizations, and the types of resources that people living with HIV actually need. So HIV is not only a biological disease, but it's a disease, it's a social disease as well. And so when we're looking at funding for HIV, we really want to make sure that HIV funding connects to other aspects of our lives in terms of our poverty, the way that we can access food, transportation, housing, all those things go together to kind of create a great picture that will address HIV issues in our community. So I know I don't have a lot more time left, but I had a different type of speech, but I'll be happy to answer any questions. So my priorities would be decriminalizing HIV and looking at funding opportunities and how we allocate funding in this city. Thank you.
And one of the things that we would want to ask each presenter is to, if they have comments in writing, to pass it along to either Dory Henry or DeAndre. Raise your hand, DeAndre. So that we'll have your comments on the record. We're going to ask Dr. Patrick Sullivan, Professor and Principal Research Investigator from Emory University, to come forward, and as he tries to get his presentation together, we'll move on. I have a question while you're putting that together. Where is Mr. Lyons?
Right here.
Can you, there's no microphone at that table right there. Are you ready? Okay, fine. Stand down, we'll let the Dr. Sullivan go ahead and present.
So first, I want to thank Representative Dawkins, Hagler, and Senator Ford for this opportunity to talk to you and to tell you a little bit about what we've been doing at Emory to try to understand more about the reasons for black-white disparities, particularly among black and white men who have sex with men in Atlanta. I want to start out by encouraging folks to look at the great data that William Lyons presented in a slightly different way, which is actually a collaborative project we do with the Georgia Department of Health. And on the slide you can see this is a map of Atlanta that illustrates the impact of HIV in our communities by zip code. And the sort of most darkly shaded areas are most impacted. On this map, the most darkly shaded areas indicate areas where over 1% of the population is living with HIV. When you compare now black rates and white rates, this illustrates the difference in rates that William Lyons presented, and shows now in this slide in the most deeply shaded areas between 2 and 3% of people are living with HIV. So online you can explore this, look at the statistics for your own zip code, and it's a way to more geographically understand how HIV impacts our communities.
Doctor, can I,
yes.
let me interrupt you for
Yes.
1 second. You say this is online?
This is available online.
Okay. If you could provide staff with the appropriate links.
Yes.
So we can go to this.
Yes.
But but tell us what zip codes are the darker.
So just to give you a sense of perspective, on this map, I'm going to try and indicate here that this is roughly the perimeter. This is a 6-county area where the zip codes are represented, and so most of the zip codes inside the perimeter are in one of the top 2 concentrations of shading. On the maps on the website, if you hover over a zip code, it will show you the zip code, the number of people living with HIV, and the prevalence, essentially the percent of people living with HIV, zip code by zip code.
Can you go to the previous slide?
Yes, I can.
And
this is overall black and white combined. So what you can see is if you look at I say the outlining counties only in the context of this map, but the further away from the city center, you can see that in those areas there's less burden of HIV disease, but when you break that down by race, communities of color in those zip codes are still very heavily impacted. So that disparity persists throughout this 6-county area. I'd like to focus more particularly on the issue of disproportionate impact among black men who have sex with men in Atlanta. I have a couple other statistics that we can put on our sort of by the numbers. Number 1, Georgia is number 1 in the rate of new diagnoses among states in this country. And number 2, Georgia is number 2 in the number of black, gay, and bisexual men diagnosed among all cities in this country. The only city with more black gay men diagnosed is New York, which has several times our population. The black gay community in Atlanta is a vibrant part of why we're the city that we are. And this question about why black gay men are disproportionately impacted is a question of national importance that's being asked in a lot of places. To try and help contribute to this understanding of why black gay men are more impacted, we just finished a 5-year study at Emory University supported by the National Institutes of Health, where we ask exactly that question. What's the reason for disproportionate impact? And I should tell you that there's a lot of research that says black gay men are not more affected because they have more sex partners, because they use less condoms, or any of the individual behaviors that you might first think would account for differences in HIV. Our job was to figure out, if not those factors, then why do disparities exist? I want to bring back the slide that William Lyons showed and make a slightly different point. These are data from over 800 men who participated in our study, and we were greatly supported both by the gay community in Atlanta and also by community-based organizations. What I want to point out is if you look at 18 to 19-year-old young gay men, the prevalence in young black and white men is about the same, 6 to 7%. That's 18 to 19-year-olds. 20 to 24-year-olds, young black men now have a 34% prevalence. I want to tell you as legislators, this is a critical period in terms of health education, health promotion, because in this short period of time, that's where this big disparity is being generated between black and white MSM. We found, as others have, that the black gay and bisexual men in our study reported fewer sexual partners, fewer sexual risks, less drug use. These black men in our study reported more same-sex partnering, but less pre-sexual discussion of HIV status. So I want to build on the previous comments and say that among the black men, there was less of a degree of discussion of serostatus before sex. The black men in our study also lived in areas of lower socioeconomic status, and I'll come back to that. So what did we find? Just without burying you in too many numbers, the young black men in our study acquired urethral gonorrhea at 10 times the rate of the young white men, rectal gonorrhea at 2 times the rate, and every case of new syphilis infection among our black and white MSM, the 550 we followed forward over time, every case of syphilis was diagnosed in a black gay man, no cases in white gay men. Overall, the new HIV acquisition was 6.6% per year among our black participants. That means for every 100 black gay men who are living without HIV on January 1st, nearly 7 of them will become infected with HIV during that year. When you look at the young black gay men, 18 to 24-year-olds, of every 100 young 18 to 24-year-old black gay men who are HIV negative on January 1st, 12 of them will become infected during that year. These are really shocking levels of incidence that we don't see anywhere else in the world. The only other comparably high estimate was among black MSM in Baltimore several years ago. So I want to end just by saying what explains this if it's not behavior. The 2 factors that explain statistically why our young black MSM were infected more frequently were health insurance, or lack of health insurance I should say, and the sexual networks of young black MSM, which may be denser and which have more black partners in them. So I want to break that down a little bit in terms of policy recommendations, because Senator Ford, I appreciate the request for policy implications. First is health insurance. I don't think it can be overstated the ways in which lack of health insurance contributes to black-white disparities in HIV among gay men. It is access to routine testing that CDC recommends and that insurance covers. It's access to routine STD screening, which may be difficult to find, especially screening for rectal STDs in the absence of health insurance. And this emerges as the predominant explanatory factor in our analysis, and all steps should be taken to improve coverage of health insurance. I want to just echo what's been said about stigma reduction, and I really applaud the state's efforts in this regard. When we think about lack of discussion of serostatus, this is about stigma against people living with HIV, but also in some cases homophobia within our communities that frustrate these discussions. So anti-stigma campaigns and decriminalization, I just want to echo the last excellent presenter and say the White House in the Office of National AIDS Policy has explicitly stated, coming from the top, that decriminalization does not facilitate HIV prevention, that in fact it frustrates our efforts to promote open discussion and to reduce HIV infection. So decriminalization should be a high priority. And I want to end by saying that we in Georgia, I think we should be proud of tremendous movement around the area of pre-exposure prophylaxis. These are anti-HIV medicines that people who are HIV negative can take to substantially reduce their risks of infection. And the challenge for us now is to get this important tool to the people who need it most. According to our analysis, many of the men in our study would have been in a risk category where PrEP would have been appropriate. And I would just say that our governmental partners, Emory and other community-based organizations are all trying to work to move forward the availability of PrEP. But I would hope that you as legislators would be aware of this as a coming issue, and it's cost effective, it's well tolerated, men are very willing to think about taking PrEP, and we haven't gotten to that phase of putting it out in a way that it is available, meaningfully available, by which I mean without barriers of excessive copays, without barriers of excessive screening process, that this is an emergency in our gay communities, and it is a dire emergency in our black gay community, and we need this tool to be more widely available. So I'll stop at that point, and again, thank you for the opportunity.
And so I I don't know if those policy recommendations are online with this presentation.
I will send them, I will
Okay.
get them to you in a separate document.
All right,
Thank you.
thank you. All right, and you'll be available for questions later. We're going to ask Devin Barrington Ward to come forward. He is a domestic advocate for ABAC, Global Advocacy for HIV Prevention. So if you come forward, Devin, and present the way you see fit, we'd appreciate it.
I don't have a PowerPoint presentation, so I'm just going to speak.
That's fine.
Okay. Can I turn this on? So I will introduce myself for those who don't know. My name is Devin Barrington Ward, and I currently reside in Washington, D.C. I serve as a member of the Domestic Advocacy Program with AVAC, Global Advocacy for Prevention. Many of the legislators gathered here may know me because before I began working in sexual health, I started off as a legislative staffer here, previously served as Chief of Staff to Representative Waits and legislative aide to Senator Jackson, another member of the caucus. My previous work experience in the legislature and my passion for improving sexual health disparities within Black communities have afforded me the opportunity to work with the GLBC over the past 2 years to host and produce several sexual health symposiums here at the state capitol. These symposiums were successful at bringing together legislators, public health officials, advocates, and community members to discuss strategies on how best to reduce the heavy burden of HIV and STDs within our communities, with a special emphasis on marginalized populations like Black gay men and Black women. This hearing is a direct result of the caucus's willingness to partner with my colleagues and I working to eliminate sexual health disparities, and we thank you for your willingness to be engaged. After our most recent symposium, which took place on December 1st, World AIDS Day 2014, Representative Dawkins Hagler asked my colleague and I, Justin Rush, who serves as the board chair for the Crip National Advocacy Coalition, to compile a series of policy recommendations that could advise the caucus and its members and other legislators seeking to address Georgia's HIV and STD epidemic. While nothing that I'm presenting here today is in an attempt to influence, support, or defeat any particular piece of legislation or proposed legislation or appropriations or regulations, this presentation and the policy recommendations are intended to educate policymakers so that they can make informed policy decisions on behalf of their constituencies. After much research and some input from our colleagues, Justin and I concluded that Georgia would greatly benefit from the adoption of several sexual health policies, which would include the implementation and education around pre-exposure prophylactics, the revision of HIV criminalization laws, an expansion of HIV testing activities, the implementation of expedited partner therapy, and funding to improve Georgia's HIV treatment cascade and rates of viral suppression. And I won't go into great detail on each one, but just give a brief synopsis on each. So for those who don't know, PrEP is short for pre-exposure prophylactics, and is one of our most promising and exciting HIV prevention tools we currently have at our disposal. PrEP, which is a proven HIV prevention strategy, is the use of antiretroviral medications that's typically used for the treatment of those living with HIV to be given to those who are HIV negative in an attempt to prevent them from acquiring the virus. Currently, the only drug approved for the use of PrEP is Truvada, which is made by Gilead Sciences. And in full disclosure, I currently take PrEP for prevention. Studies have shown that if taken daily, Truvada can greatly reduce an individual's risk for contracting HIV by upwards of 96%. Despite it being highly effective, significant barriers do exist for people who want to access PrEP. And those barriers could include cost, knowledge, and difficulty finding medical providers who are either knowledgeable about PrEP or willing to prescribe PrEP. And for these reasons, it's one of our recommendations that the GLBC embrace policies that would help the uptake of pre-exposure prophylactics in Georgia. And Georgia can learn from several other states and municipalities who have embraced PrEP policies. The first being Washington State. Their Department of Health announced in April of last year a pre-exposure drug assistance program, pre-exposure prophylactics drug assistance program, which is modeled after their AIDS drug assistance program, which we also have here in the state of Georgia. And so essentially it provides financial support to those who are eligible individuals interested in using PrEP. The support includes the cost for co-pays, for insured individuals and full coverage for uninsured or underinsured individuals. Also, the state of New York, Governor Cuomo announced a very ambitious plan last year, essentially calling the Bend the Curve plan, which would essentially end new cases of HIV in the state of New York by 2020. And one of the main components of that plan is to provide access to pre-exposure prophylactics for high-risk people. And then finally, on PrEP, the city of San Francisco introduced legislation that would allocate about $800,000 to pay for health navigators to increase education and do an education awareness campaign about the effectiveness of the drug. The second and probably the more controversial recommendation is the revision or the elimination of Georgia's HIV criminalization laws. Currently, legislation in the state of Georgia concerning transmission of HIV is rooted in antiquated science, promotes stigma, and serves as a fuel for the HIV epidemic in our state. HIV criminalization is the inappropriate use of using one's HIV status in criminal proceedings. Statutes that punish the failure to disclose one's HIV status prior to engaging in sex or enhances sentencing for HIV positive people with certain crimes creates a shroud of stigma that renders those whose status are unknown unwilling to seek HIV testing. And so essentially, these HIV criminalization laws are really reversing everything that we try to do in public health and HIV prevention. Georgia actually has a specific statute, and our HIV specific statute that's on the books, it was originally designed to lessen HIV incidence. However, that rationale cannot be backed up by any science or statistics. Under the current prosecutions, under our current HIV-specific statutes, HIV transmission is really a factor, with less than 10% of the cases involving the actual transmission of the virus. So essentially, someone is dragged into court, is arrested, charged under the HIV-specific criminal statute, and they may not have even transmitted the HIV virus. In addition to that, many of these cases, about 25% of these cases, are for spitting, scratching, and biting, which according to the CDC carries virtually no risk of opportunity for transmission. Also, it doesn't take into account whether the person used a condom or if they are virally suppressed, which we both know is effective at keeping someone HIV negative. And so what Georgia can do about it is accurately reflect the current science of risk and modes of transmission into our laws, adequately reflect the quality of life and the lifespan of individuals who are living with HIV, account for circumstances where the failure to disclose is directly related to intimate partner violence, and modernize existing statutes to reflect our most current laws, our most current data and research. The other recommendation is the expansion of HIV testing. In 2006, the CDC made recommendations that opt-out HIV testing be a part of routine clinical care in all healthcare settings for adults and adolescents aged 13 to 64. The opt-out testing preserves a patient's right to decline an HIV test and ensures a patient's provider's conducive for a patient-provider relationship that is conducive for optimal clinical and preventative care. Recommendations like this can be extremely beneficial and can have a major impact on our most marginalized communities like Black gay men. Some studies have shown that nearly 50% of gay or bisexual men have reported that their doctor has never offered them an HIV test. That's unacceptable. Several jurisdictions have already passed similar legislation like this. That would include Illinois, New York, and the District of Columbia. All providers are either encouraged or required to routinely offer and recommend that patients have an HIV test. In Georgia and across the country, an estimated 1 in 5 people with HIV are unaware of their status. This is extremely counterintuitive for our HIV prevention efforts because if one does not know their status, they can't take the appropriate procedures to make sure that they're keeping themselves safe and their sexual partners safe as well. In addition to that, while viral suppression is very important, we can't get to viral suppression if we don't even know what your status is, because we aren't able to effectively link folks to care. I know that we currently have an HIV expansion of HIV testing bill that's being considered. However, some advocates have made it clear here in Georgia that they would like to be more embraced in the process, and I've communicated that to Representative Waits, and we hope to move forward with the community at large in terms of a revised version of the bill. The final thing that I'll talk about is expedited partner therapy in Georgia. And that's, I'm sure Michelle is like back there shouting or raising her hands. But essentially, I know everything that I talked about was very HIV focused, but this also focuses on the other side of the epidemic, which is STDs.
Okay, we're gonna need you to wrap up
Yes.
in about 1 minute.
Okay, so expedited partner therapy is the clinical practice of treating sexual partners of the patients diagnosed with a sexually transmitted disease without clinical assessment of the partners. This is typically accomplished by a clinician providing prescriptions or medications to the patient to give his or her sex partners. EPT allows a healthcare professional to provide patients with antibiotics or prescriptions for their partners without requiring a visit for the patient. And so this is really important because a barrier for treatment for STDs can oftentimes just be the stigma and the shame of not wanting to come into a doctor's office to get that type of treatment. And so what EPT essentially does is allows me, let's say that I have an STD and I decide to go to my doctor and say, hey, my sexual partner would like to have the prescription as well. They don't have to come in for a visit. And so in Georgia, we have a quasi, it may be allowable, it may not be allowable. And the CDC made recommendations that EPT is something that should be embraced throughout the country. Several states have already passed similar legislation, and the one thing that Michelle always likes to say is it's never acceptable for Georgia to be behind Mississippi or Alabama in anything, especially football. And Mississippi and Alabama have both passed, have made EPT allowable. In Georgia, we still are in a quasi-state in terms of whether that's allowable or not. So those are the series of recommendations. I've already submitted some of that to Danica, and I will submit the full version of the policy recommendations within the upcoming weeks. Thank you for the opportunity to speak with you all and work with the caucus on this issue.
Thank you. We're going to ask Dejan Dixon-Diallo. There you are.
I'm right here, trying to line it up and be ready for
We
it.
appreciate you. She's the founder and president of Sister Love. Thank you for being here. And let us hear from you the way you.
So thank you so very much, Senator. And thanks to everyone for being here. And just in case, before I even get started, do some housekeeping. If you are tweeting, we've created some hashtags for you, just in case you didn't create your own. So if you are tweeting or sending out messages, Black AIDS, we have hashtag Black AIDS in Georgia, hashtag End HIV in Georgia, and we also have hashtag GA Test for HIV. So use those as you talk about today, which I think is a really powerful, important and historical testament to the leadership that we have before us. So I also want to thank you for inviting me. Thanks to Danica, of course, for sending the invitation. And I want to greet the leadership of the Legislative Caucus, especially my own, Senator Vincent Fort, as well as my representative, Mabel Thomas. It's already been said who I am, so I'm going to pass through that and try and get through a little bit of time that I've got. There's been a lot of data and epi that's been presented, and I had some of the same to share with you, but I think we also want to make sure we locate a lot of that data inside and in the context of the social issues and also the cultural and economic determinants that are happening within the communities, particularly in those zip codes that were shared before. I could easily say ditto, ditto, ditto to everything that's been said before, but I think it should not be missed that we are nearly 34 years into an epidemic that's taken away millions and millions of lives, and every single one of those lives has a huge story that's connected to a whole bunch of other lives, and we should never forget that. And to remind ourselves that while we can talk about some of the things that are working and some of the things that are being done, we are not winning. During the last decade, there have been fewer AIDS-related deaths, but in Georgia, individuals with HIV, in fact, are living longer. A lot of this shift is due to some of the strong public health responses. But let's not be confused that Georgia has remained in the top 10 states in the United States for over 30 years, and we just recently ticked up to number 5. So that's a dubious distinction that we don't need. We also want to say that in the midst of all of those numbers, that factors like poverty in those areas, unemployment, inadequate access to health care and sociocultural issues, increased opportunity for incarceration, reduced opportunities for higher education, and all that goes on, are also concentrated in those same communities. An estimated 8% of Georgia residents engage in some form of illicit drug use. Late diagnosis is associated with a shorter lifespan compared to those with earlier diagnosis, and twice the lifetime risk of transmitting HIV to those who are diagnosed early. So late testing itself results in missed opportunities for prevention and treatment and HIV infection, and it emphasizes the need for earlier testing. There are 10 states that account for the majority of women living with HIV, and Georgia currently ranks 8th. And inside those numbers of women in the state of Georgia, 75% of them are black. And there's a whole host of issues that I described, and I'll submit the written comments to you so you can get the full of that. When we talk about women, however, I would also want to make sure that we shift our thinking to include women who were born physically identifiably, however you define it as women, and women who are transitioned into womanhood. So transgender women and transgender individuals are a part of that LGBT cohort that we always talk about but somehow leave behind. So I want to make sure that the T is always a part of the conversation. I also want to just echo what Devin was talking about in terms of the new tools. And there are other tools, especially with regard to policy and guidance, in addition to the science that he's laid out with PrEP and pre-exposure prophylaxis and post-exposure prophylaxis and treatment as prevention. But we have tools that have been issued at the national level that we have yet to tap into inside the state of Georgia. In 2010, the President released the National HIV/AIDS Strategy. We are 5 years into a national HIV/AIDS strategy. We have yet to have a statewide Georgia strategy to say where we actually want to go to coincide with what others are doing around the country. The President instituted by executive order the Interagency Working Group on HIV, Gender-Based Violence, and gender-based related health disparities. We have yet to look at the true meaning of our policies and practices of the intersection of violence, all forms of violence, and not only against women, but the role that violence plays in our communities where HIV is rampant. We also have the care continuum, and thanks to our state Department of Public Health and our epidemiologists and our teams there, we currently have a care continuum. We have a care continuum, but with a 1% or less rate of HIV infection in the state of Georgia, and that's not small. But what that means is that 99% of the people that we test for HIV are going to come back negative. And if we have no continuum for people who are not living with HIV, then we are simply waiting for them to be positive before we figure out all of the other social and health needs that all of our people need in order to curb the epidemic itself. We have hepatitis C screening and new treatments that are effectively the cure. And we have a huge challenge around how that's going to be afforded in our Medicaid system. We have state departments, we even have our AIDS drug assistance program at the state of Georgia that is currently telling us that they're not able right now to cover those treatments for all people living with HIV who are also co-identified or co-diagnosed with hepatitis C. That's unacceptable. We also know that housing is prevention. And in those same districts, those same zip codes that we've already talked about, we also have a really dismal number of housing opportunities, affordable and long-term. So there are a lot of things that are working, and I could go on with the good news today, but that's okay. You'll have it in writing, and we can celebrate when it's really all won. But what's not working is that we still don't have equal access to quality health care and supportive services throughout the state. It's not acceptable that so many folks have to come to Metro Atlanta to seek their care, especially in the light of dwindling access to health and or stigmatizing and discriminating behavior inside wherever they're going, private or public, for health care. There's not a coordination yet among a diversity of bodies that are intended to plan. We don't have a statewide body yet that currently advises our legislature or our gubernatorial office on what's going on around the state in HIV. We had one, we need one. It should be put into place immediately. And I'm okay if you decide to do it for black folk first. Now, I'm going to put this off and then I'm going to sit myself down because my clock just ran out. I mentioned the statewide strategy itself, but I also want to mention the fact that we have a dearth of leadership. And so while we can talk about the policies, I agree in supporting a policy around decriminalizing HIV, expanding Medicaid, and other health funding mechanisms. I also think we should revisit and never step away from providing the comprehensive sex education which raises equality for sexually active teenagers in the state of Georgia, that we expand testing and linkage to care, that we fund these things, given the fact that we have no line item in the state of Georgia's budget for HIV prevention. That too is unacceptable. But in addition to the policy work, I just want to remind the fact that you all exist as the Georgia Legislative Black Caucus is inspiring. The fact that you pulled us together to have this conversation is beyond meaningful. And so in addition to policy work, the other work that has to be done is we need you as our champions. We need the true champions to help eliminate stigma, to get folks tested, to get folks into care, to see you engaged and caring and involved in these issues, to work towards integrating comprehensive sex ed in our communities if we can't get it into our schools first, to elevate the attention to the most affected populations throughout our state through your own communications or media campaigns, community events, local involvement, and the lifting up of our HIV positive leaders. So I wouldn't close if it wasn't inspirational. The belief systems matter. And it's all about the love and dignity and the quality of life that we hope to have for all Georgians. And so I encourage you to embrace total compassion, zero condemnation. Zero in on your dedication and zero out all discrimination. Elevate the support we need, eliminate the stigma we've been living with, engage and embrace HIV positive leaders, get informed and forget the ignorance, and lead with love to the end of HIV in Georgia. Thank you. We also gave you some handouts, and I can do a follow-up note with our comments on what has been provided to you around the workforce in Georgia and talking points, and I thank you again for the opportunity today.
Devon, thank you for I think it was entirely appropriate for you to be the last presenter in that segment of our program, because it is always important, I think, to end on a note of hope and inspiration. So I appreciate that, because leadership really does matter. As I'm sitting here, I get myself in trouble a lot by saying what's on my mind and saying it strong and hard. But, we may, as a Black Caucus, want to consider at some point a 10-point program, the Georgia Legislative Black Caucus, 10-point program on Georgia's HIV epidemic. What do you think?
Yes.
We've listened to you. This is at least a second kind of event of this sort that we have heard. Maybe we need to start establishing a 10-point program of policy recommendations, legislative and policy recommendations. So, because ultimately people are looking to us for what? Yeah. Leadership. I'm going to make a comment, and then I'm going to open up the floor to my colleagues for questions. But I do want to make a point about the Medicaid expansion. 650,000 people in the state of Georgia would be eligible for health insurance if the governor and the state legislature made the decision to do Medicaid expansion.
Yes.
3,000 people died last year because Georgia did not do Medicaid expansion. What does that mean? Another 3,000 will die this year. And these are conservative numbers. Harvard University did, I'm basing my comments, my numbers on a Harvard University study that analyzed this. So Medicaid expansion is critical. If some of you who have listened or read in the media know that in the last few weeks, It was announced, some of us don't know it now, and some of us didn't know it when the media got it, but that the Republicans in the Senate have created an informal ad hoc committee to look at Medicaid expansion. Did you know that? And, I mean...
Are you on it?
No, I'm not on it. They didn't include me in that. But it's very important, and this is a very important point, before them to have created an ad hoc committee on Medicaid expansion kind of very quietly is very, very important. That, I mean, they're losing, you know, aside from the thousands of people who are dying for the lack of Medicaid expansion, Georgia's also losing out on what? Tens of billions of dollars per year and tens of thousands of jobs and economic development. So, you know, it's a public health issue, but it is also what? An economic development issue. Whereas other states, Republican states, are doing what? Doing Medicaid expansion. Arkansas, Arizona, New Jersey, right? Tennessee. And as a matter of fact, I'm preparing a bill even as we speak based on the Tennessee model. You know, I'm not crazy about the Tennessee model. I've said it before, I believe in what? A single payer healthcare system. Medicare for everybody. You know, short of that, you know, the Tennessee model is not perfect. I prefer another model, but we're going to introduce that to send the message. But I at least wanted to let you know where we were in terms of Medicaid expansion. Will it happen this year? Might it happen next year? But we have to have a strategy, a community-based strategy on Medicaid expansion, and that's why one of the things that I hope you would do is get involved with Moral Monday Georgia, which has been the lead organization on the Medicaid expansion issue. They're going to have an action this coming Monday on Medicaid expansion, and you should go to their Facebook page, their Twitter account, and Moral Monday Georgia to see how you can be engaged, because that may be the most important public policy issue, because it's a matter of what? Life and death, right? I mean, it's going to impact directly whether people live or die. Having said that, if any of my colleagues have questions for any of the presenters up to this point, Senator James.
Thank you, Mr. Chairman. I do, well, this has been an eye-opening experience, even though I knew many of the statistics, and I'm very, very interested in eradicating HIV one day. To look at the youth and the increases, I would like to ask someone who might be working to educate our youth. The numbers seem to be escalating. I know that many people think that this is not a death sentence anymore, because after almost 35 years of an epidemic, many people are living much longer and being able to be treated. But I want to prevent it with our children. I want to see more go into prevention. So is there anyone that is out there that's working with the children? Yes.
You want to come to the mic? Thank you.
Good afternoon. My name is Masani Trailer. I have on a t-shirt right now. On the front of the shirt it says, I have HIV. And on the back of the shirt it says, if only it was just that easy to tell, get tested. I was diagnosed HIV positive 4 years ago at the age of 23. And 2 weeks after my diagnosis, I had found out that I was pregnant. I was not offered HIV testing. I requested it from my private doctor's office that I had been going to when I found out that I started my menstrual cycle. So I had a very close relationship with them. I have been partnering with Sister Love, Aid Atlanta, the Georgia Department of Public Health, and several other aid service organizations. I go into middle schools, high schools, in college settings here in the state of Georgia. More recently, I was at Spelman, Cedar Grove High School, Towers High School, Sequoia Middle School. I've been through DeKalb County and Fulton County mainly, and then in the rural area, I've been to Savannah State to conduct a focus group there. When I go into the high schools, what I've noticed is that the students don't have a lot of education. It is very watered down. It's still the exact same way that it was 10 years ago when I graduated from high school. They basically tell you that you can contract any STD. Some are curable, some are not. And if you get HIV, then you can possibly die. But then you hear rumors that there is medication available and out there in treatment. They are made aware that we cannot talk about prevention as far as condom usage is concerned. We do tell them that the 100% way of not contracting any sexually transmitted infection or disease is by staying abstinent. The teachers, the faculty and staff, they're very leery about talking about any type of prevention methods. What we do is we do educate them about viral load and T-cell count, and we do let them know that as young as age 13, you can get tested without parental consent throughout the state of Georgia for free. We do offer them testing site resources and places that they can go to. We do not offer help with transportation on how to get there. We do offer them a 1-800 STD hotline that is provided by the state as well as CDC. As a participant in the CDC Let's Stop HIV Together campaign as well as the Greater Than AIDS campaign, I realized that there is also a lack of awareness amongst the youth. The type of questions that they have and the visibility around HIV/AIDS awareness is extremely low. The amount of education and research that we now have, it is a shame that a lot of young people between the ages of 13 to 24, when they're coming in to get tested, when I talk to my colleagues and people who support me as well, they're not coming back with an HIV diagnosis, they're coming back with an AIDS diagnosis. So they're waiting too late to get tested. And they are fearful of coming to their parents. They kind of conjugate amongst each other for information around HIV. Going into the schools is very tricky, depending on who you talk to. It could be a counselor or PE coach or health educator as far as getting into the school to come and do personal testimony that I share with some of the people that will come up and speak later. When we do go in, we do say abstinence only once again, but the language around the sexual comprehensive health and the policies do not statewide does not say that it has to be abstinence only. They say that it's up to each county to do that, but each county, they're so left and right, they're not sure what the language is. They just stick to abstinence only. So if that could be something that could also be addressed, that would be so helpful as far as when it is attentive to the young people, but also offering HIV testing in private healthcare settings, not only public healthcare settings, would be extremely helpful, because that was something I was very headstrong about taking care of my health, but my friends were not as bold as far as requesting to be tested. I would have to encourage them and advocate for them, as still to this day in my late 20s and their early 30s to do the same. So.
I thank you for what you've done. Is it okay if I say one more thing?
We've got about
I want to make a suggestion.
Yeah, and we've got about 16 people who are on our list.
Okay, I just want to ask you, Senator, since you had suggested a 10-point program, that we make sure that youth is as close to the top, youth prevention, since that's something that seems to be lacking and the numbers seem to be increasing. I'm sorry I have to leave too, I have to go to another meeting.
Okay.
But
yeah, that's fine, and I'm sure I don't think anybody's going to disagree with that. Representative Alexander, did you have a question you wanted to address? Yes, ma'am.
I want to certainly appreciate all of you coming to this important issue right here. Whatever I can do, I'm available to help. So wanted to ask Madam Chair and Mr. Chair whether or not we can get these in presentations. We can get the presentations that they provided with these stats and these numbers, if that's possible.
I think what we're going to try to do is collect all the data, presentations, PowerPoints, links, written data, written testimony, put it in a packet, and try to get it electronically each and every member of the Georgia Legislative Black Caucus.
Thank
So
you.
that's something.
Very, very informative.
All right. Okay, what we're going to do is transition into public testimonial. Ms. Traylor began the process, and we're going to ask, we have these names in alphabetical order. I thought we were able to stay here until 4:15. In fact, we're going to only be able to stay here until 4 o'clock. So I'm going to ask people to come to the microphone in the order that I call you. And as I call the first person, the other people that I call should line up behind them, okay? Can we do this in order? If you have to leave, please leave quietly. And we're going to ask, first of all, for Cynthia Allen. Go right ahead.
Hello, I'm Cynthia Allen. I'm an advocate, a motivational speaker. I partner with Sister Love, Aid Atlanta, Aid Gwinnett. I give back to the community. I am HIV positive. I've been positive in April, will be 21 years. When I first got diagnosed, didn't think I would be standing here 21 years later and not doing some of the work that I'm doing back into the community, and like to see other things take place because of the things I have been through. It's been a long road with the stigma, housing, insurance, testing, education. I think what I am experiencing in the community, along with Messiah, we go out to the schools, and we're on the Speakers Bureau, and we go into the schools and we educate as much as we can, but also I focus on the seniors, 50 and above, because that's a great deal to my heart, because my mom is HIV positive, and it's just a lot. I'm just a little nervous today, but I just want to say thank you, first of all, for having me here today and to address some of the issues around the stigma, housing, insurance, linkage to care. That's all I can say right now. Just full. Thank you for having me.
Thank you for being here. Tell us your name.
How are you? All right, my name is Elvette Bentley, okay, and currently I'm working in the HIV community as a linkage specialist, okay? In that position, I'm responsible for treatment and care, education and awareness, psychosocial and emotional wellness. And since I've been in that position, we do testing. And a portion of that testing, there's a form that we must fill out called risk factors. And all those risk factor forms, what I found that we ask people a whole bunch of questions to find out whether or not they fall high or low for HIV, okay? But what I've found, most people that are at the highest risk for HIV are the people that don't believe that it can happen to them. Those are the highest risk factors, and I can say that from personal experience because that was my situation. I didn't believe that it applied to me. And then at 28 years old, while 6 months pregnant, I received my diagnosis. And be that as it may, I would go with the cliche of saying, if I had known what I'd known then, what would I have done? I can't really tell you what I've done, would have done differently, but what I can say is that knowing is better than not knowing. When you go into, and between the ages of 16 and 28, somewhere along that line is when I was exposed to HIV. And 16 to 28, I had several primary care physicians visits, several OB/GYN visits, and even a couple emergency room visits in between that time. And never once did anybody ask me, did I need to get an HIV test done? And that's because I didn't meet the risk factors. And as a result of that, I'm not going to say that It's and I'm a little bit nervous. This is my first time speaking before you all. At this point, what I am hoping is that what happened with me does not happen with my daughter. I want them to have the option that I did not have, and that is to get tested in enough time so that I can know my status, and then you can make better choices. Thank you.
After Emily Brown, Jaquel Clemens, Miller Ford, and Deborah Glover should come in that order. Clemens, Ford, Glover, Emily Brown.
Hi, thank you. I'm Emily Brown from Georgia Equality and the Atlanta Coalition for LGBTQ Youth. I had a lot of things prepared to say today, but frankly, I think it's not my voice that you need to hear. The Atlanta Coalition for LGBTQ Youth came up with a series of policy asks about youth HIV in Atlanta. I care deeply about this issue, but I'd really like for Mickey Bradford to present this. Mickey presented this at the World AIDS Day Policy and Action Breakfast on December 1st, and I think Mickey can do it much better than I can, so thank you.
Thanks, Emily. So my name is Mickey Bradford. By day, I coordinate linkage to care at Mercy Care, and after hours, I work with the Atlanta Coalition for LGBTQ Youth. Recent studies suggest that 60% of young Black gay men will become infected with HIV before they turn 30. I'm 24 today, so when I think about how urgent this epidemic is, the fact that there are only 6 years until I may or may not contract HIV, this is not only professionally and politically important, but this is personally important. And so I wanted to charge you with a couple of policy asks. First of all, in our schools, we really need to support the implementation of comprehensive sex education. This needs to be inclusive of LGBTQ individuals so that we know exactly what our sex education options and tools are. This needs to also coincide with making our schools safe spaces for LGBTQ students, safe spaces to form gay-straight alliances, safe spaces to go to their school nurses and talk about sex openly. When we think about healthcare, we need to expand minors' access to confidential HIV and sexual health services. Every young person needs to know that they have the right in the state to get tested for HIV without their parents' consent. We need to also expand Medicaid here in Georgia. We need to make routine opt-out HIV testing available throughout Atlanta, and Mercy Care is proof of that. It works. We need to make pre-exposure prophylaxis, PrEP, available and accessible. And I speak as someone who has had to navigate his own friends through the process of getting on PrEP and through the process of getting on post-exposure prophylaxis, which is in the event that you come in contact with someone who may or may not transmit HIV to you. And in the sector of housing, we need to have LGBTQ youth are far more at risk for homelessness, and this also coincides with risk for HIV. I sit on the board of directors of Lost and Found Youth, the only organization working actively to bring LGBTQ youth off of the streets. This is terrible, and we have to do more work at the intersections of housing, healthcare, and HIV. Finally, sorry, the timer just went off. 60% of young Black gay men here in Atlanta will become infected with HIV before age 30. And I have to think about this timer going off, feeling like a timer that is above my head, wondering when this will happen to me. I wear this pin, this STI pin, as a survivor of sexually transmitted infection. And I have to think about the co-infections between gonorrhea and HIV. And so, as a 24-year-old Black gay activist, I have to hold you personally accountable for policy and action I cannot accomplish alone before I turn 30. We have only 6 years. We are already 5 years into the national strategy. The time is now, the time is now, the time is now. Thank you for your time and attention.
Hi, my name is Jaquel Clemens. I am the coordinator of routine testing at Mercy Care. Mickey actually just echoed a lot of the sentiments that I would express. So I'm not going to go over those again for the sake of time, but what I will do is defer to my colleague Mara to talk a little bit about how routine testing has impacted our Hispanic population.
Buenas tardes. My name is Mayra Oquendo, and I am an employee of Mercy Care North. Mercy Care is a federally qualified health center. We primarily serve the Atlanta homeless population, but our North Clinic provides care to Hispanic patients. On average, we provide care to between 150 to 175 patients a week. Today, I would like to focus my remarks on gaps in HIV services for Hispanics. My remarks are solely based on my experience at Mercy Care, where we have implemented routine HIV screening in 2013. As a result of routine screening, my eyes have opened up to gaps in services for patients who were newly diagnosed as HIV positive and Hispanics. I want to talk to you about missed opportunities. By missed opportunities, I mean patients who will have been screened, who will have not been screened for HIV if we were only screening patients based on perceived risk. For an example, at her first time assessing care at Mercy Care, a 41-year-old woman present for shoulder pain. She is offered an HIV screening by our medical provider. She is single. She's a single mother of two. At diagnosis, her CD4 count, which measured her immune strength, was at 135. A CD4 count below 200 is an AIDS diagnosis. Unfortunately, her case is not the only one. For every Hispanic patient newly identified through routine testing, I'm just going to repeat that. A CD4 below 200 is an AIDS diagnosis. Unfortunately, her case is not the only one. For each of our Hispanic patients newly identified through routine HIV screening, I have an equally alarming story. This is a consistent pattern for our Hispanic patients. The HIV rate of newly identified Hispanic patients at Mercy Care is twice Atlanta's average. 67% of our newly diagnosed Hispanic patients present with CD4s less than 200. This means that we are diagnosing Hispanic patients far too late in their infections. While our patients are easily retained in care, testing and education continues to be a challenge for all of the obvious reasons: stigma, fear, English-only services, lack of targeted awareness, and insurance. I am here in support of routine HIV testing. If we are interested in reducing HIV disparities, I am pleading to please include Hispanics in this discourse. As Hispanics is an ethnicity. We are not a race. We are Black, we are white, Asian, Native Indian, and multiracial. As any other group, we are mothers, fathers, straight, gay, and transgender. Somos el sur. We are the South. In summary, I am suggesting a gap analysis should be conducted to look closely at trends in testings and care of our population. This will inform the urgent need of Georgia to implement routine HIV screening in all of primary clinics. If we are to be successful in addressing the HIV epidemic in our state, I am asking that my points are considered. Ahora es el momento. This is the moment. Somos el sur. We are the South. Gracias, and thank you so much for the opportunity to speak in today. Thank you.
Good afternoon. Jamila. Good afternoon. My name is Jamila Ford, and I'm actually an HIV prevention coordinator at AID-WNAT. One of the primary responsibilities that I have as an HIV coordinator is to provide HIV testing and counseling at our agency, as well as in the community at the sites of some of our partnering agencies. I won't go into the statistics for the sake of time for the state of Georgia, because they've already been stated by Dr. Sullivan, Mr. Lyons, and Ms. Dixon Diallo. So I'll just give you a snapshot of what we see at AID-WNAT. Through our testing services at the agency, generally we test about 2,000 individuals annually. 70% of the patients tested and newly diagnosed HIV positive in 2014 were African American. The average viral load of the African American newly diagnosed patients at intake was 282,251. There were actually a few individuals whose viral load was greater than 10 million. This lets us know that African Americans are diagnosed late in the course of HIV infection, and that there needs to be an increase in prevention efforts that focus on early HIV diagnosis. After 6 months of being in care at Aid Gwinnett, the average viral load of the newly diagnosed HIV positive patients decreased to about 24,000. The agency's viral load suppression rate in 2014 was 82%. We are extremely proud of our efforts to link our patients to care and to keep them in care because, as you know, viral load suppression significantly reduces the risk of transmitting HIV to others. The more HIV positive African Americans we can test, get into care, and suppress their viral loads, the sooner we can reduce the community viral load and prevent new infections in the African American community. What we need is your support and commitment to continue to fund our programs so that we can continue the work that we do. There needs to be an increase for funding for programs that heighten prevention efforts in our African American communities where HIV is heavily concentrated. There is also a need for increased access to HIV screening. HIV testing is the basis for prevention and treatment efforts. The rates, like someone else also said today, for HIV infection in youth and young adults are increasing expeditiously. Programs that reduce stigma around HIV testing and free preliminary HIV testing should be made available at youth service organizations, juvenile detention centers, and other youth programs. And I hate to sound like a voice recorder today, but the need for comprehensive sexual education within our schools, taught by health education specialists that are culturally competent and able to deliver the message in a manner that is relevant to our youth is very important. Thank you for your time today and for your willingness to partner with us.
Thank you so much. Deborah Glover, Dr. Hankin, Damaris Henderson, Jaquan Huber. Okay.
My name is Deborah Glover, and I represent Columbus, Georgia, Muskogee County, and the around counties, Marion County, Sumpton County, Randolph County. I work in the rural areas with the teenagers with a group called Swag and Lace. And what we do is we educate, prevention, Swag and Lace, and we work with teenagers aged 13 to 20, and we educate them with STDs and teenage pregnancies. They have a course where they take the babies home, HIV, and what I do, I personalize HIV to them. I've been living a positive life for 24 years, and I do this work because I am needed for the teenagers or the legacy. I'm going out the door. I'm 62 years old, so I need some young people to know about HIV and STDs so they can carry on and educate their peers throughout the years, because by 2020 I would like to have cure. And that's what I do. I work with the teenagers, senior citizens, and extended sisters, and I work with the poorest counties in the district in Columbus, Georgia. The rural areas where there is funding is cut. And I work with an organization called Columbus Wellness Center, and we get a grant, and this is our 5th year of working with the teenagers in the rural county. And thank you.
My name is Dr. Abigail Hankin. I'm an emergency physician at Grady Hospital. I lead the routine testing program at Grady. I want to speak directly to the importance of routine testing and the feasibility, both in the form of House Bill 53 put forth by Representative Waits and in the form of Medicaid expansion in Georgia, including a coverage for routine HIV testing. At Grady, we've instituted routine testing for nearly 2 years at this point. Not a day goes by that we do not identify someone who is HIV positive that didn't know they were before they walked in. Not a day goes by that I don't interact with a patient who is in their early 20s and has a CD4 count in the double digits and is not in care. We are one of the busiest, if not the busiest, emergency department in Georgia. We have made room for this in our triage and patient care process. It does not slow down care. It does not complicate care. In fact, there is no physician I've ever met who can take good care of a patient if they do not know if the patient is HIV positive. So it is feasible, it is doable, it is necessary, and it's important. Thank you very much.
Damaris Henderson.
I am.
And you're going to be followed by Jaqueen Hubert, Stephanie Laster, and Phyllis Malone. So if people could follow her to the microphone in that order, go right ahead.
Actually, I would like to stand back with all that has been said and with the time and give my opportunity to Craig Washington.
Let's do this. Thank you, Damaris. I love my community. I do. It's all about just, we engage a lot in terms of the work and data, and it's also about how we treat each other so much. So my name is Craig Washington, and I'm an openly gay black man. I've been living with HIV for, it'll be 30 years in May. So I'm on the brink of 30 years. And so I also serve as a prevention programs manager at Atlanta. I'm responsible for the oversight of 3 gay men's HIV prevention programs. But regardless of my profession, this would be, as Mickey said, this would be a priority issue for me because of how this epidemic has affected my community for more than 30 years. And because I believe that all black lives matter, including black transgender lives, black gay men's lives, black women's lives, poor black people's lives, and black young people's lives. And I trust that these lives matter to you, or else I wouldn't be here. So it's on behalf of those lives that I really urge your commitment and increased commitment in addressing this issue on our HIV STD prevention goals throughout the state of Georgia. So our rates of infection and prevalence, the sheer number of people living with HIV are among the highest in the nation. Particularly for young black gay men, young black queer men. And so must our prevention efforts be also elevated, coordinated, sustained to the level of a statewide HIV/AIDS prevention or AIDS strategy, and that be the highest in the nation. We need to increase our capacity not only to get more people tested and linked to care, regardless of their serostatus, but also to keep them in care, retain them, so that so that they are more likely to reduce their viral load, less likely to pass on the virus, and lead healthier lives. As Devin mentioned, we must invest in the most promising HIV prevention tool in a long time, and that's pre-exposure prophylaxis. We need the state not only to provide access to PrEP, but also ensure that our healthcare providers are trained. Far too often I'm hearing stories that are troubling about people that are seeking PrEP, and their physicians, people who you would think would know, don't know. And so that training initiative is a key part of our response to this epidemic, particularly in the rural areas. So it's not only about educating communities, it's about educating the healthcare workers, and particularly those primary care physicians who will be seeing people that are HIV negative. Such training must also impart greater cultural proficiency so the providers know how to treat people with dignity and respect. And I'm talking about cultural competence, I'm talking about cultural proficiency, right? So if I go to a healthcare setting and I'm treated a certain way, if when I mention my sexuality and my choices and my relationship dynamics with my partner and my provider's frowning a certain way, that's going to have some influence on my willingness to continue to seek care. And so we have to equip our folks to treat folks that are already marginalized due to race and socioeconomic status and gender, presentation and sexual orientation. Georgia needs policies to fund resources such as housing and job training and linkages, so that we're not, and I'm not just talking about those resources in terms of more jobs and more training, yes, and more housing, but I'm also talking about policies that ensure that people are treated with dignity in shelters and our transit housing, where too often our transgender folks, our queer folks are not treated with dignity. Their identities are not respected. And so when I mean housing, I mean not just in terms of quantity, I'm talking in terms of quality. And so we know that if people are not if they don't have stable lives, then they're rendered even more vulnerable, not only to HIV issues, but other health outcomes, incarceration, chronic poverty. So we need housing that is managed by policies that ensure the fair and dignified treatment of people. The communities most affected by HIV are also affected by stigma, targeted by stigma and trauma and discrimination. So I ask in that regard that the caucus loudly and collectively denounces a so-called religious freedom bill. Yeah, because it's a thinly, just like the so-called voter fraud protection bill, it's a very thinly, very tackily disguised application for a license to discriminate.
That's right.
That's all it is. And we need your voice, your raised voice, to address that, because we know that that bill will have a harmful impact on those who are already marginalized and disproportionately impacted by HIV/AIDS. It's a threat to their sexual health and reproductive rights, and so we need your collective voice raised high in opposition. Finally, I believe, when I talk to people about the change and shift in terms of providing real sex education, comprehensive sex education, and anti-bullying policies in schools, I keep hearing that it's on a county level. We need a statewide policy. And so I'm willing to learn and talk more about how we can mount that. GLSEN, Gay, Lesbian, Straight Educators Network, has a proposed statewide legislation, because we need safe schools so that people, regardless of their sexual orientation, can feel safe, can feel welcome in their schools. We also need comprehensive education so that people, regardless of whether they're sexually active or not, they're prepared to protect themselves. So I just want to leave on that note. I just want to say, Senator Ford, how much I appreciate your leadership. And I remember asking a representative who's no longer in office to come to Evolution Project, and that's our program for young black, gay men, and transgender individuals. And this one representative who's no longer in office, I asked him to come to an open house just to show up and show support for our folks. And he said, well, Craig, I'm not gay. I need to remind you of that. I didn't ask for your sexual orientation. I just wanted you to come and show up and remind folks, or model that they matter. They matter enough for you to show up. I thank you, Senator Ford, because you always show up. And I appreciate that. You never felt like you had to remind me of your sexual orientation, or even actually stated it. You showed up. So thank you for modeling that for the rest of your colleagues.
What is the status of the room? Danica, are we 4 o'clock?
Later. 4:30 is good.
Okay, 4:15. Okay, we're going to ask, but if I know y'all, people have been here for a while, but we've got some important things we need to discuss before we leave. We've got some takeaways, because we got some important commitments to make, right?
Your mic on.
All right, so you're going to see history being made in 15 minutes. So you can go if you want to, and you're going to miss history being made. Okay, Ms. Hubert, if you can come.
Stephanie Laster. Hubert is not speaking.
Okay, Ms. Laster, come on forward.
I stand here today with a sign saying testing saved lives, and my shirt says together we are greater than AIDS. I can tell you my story and it won't be long, but I am one of those clients that was presented in a Grady emergency room, and they offered me testing, and it saved my lives. But I have friends who have been to other doctor offices and other emergency rooms. They were not afforded that same choice that I had, and they ran around for years to find out, after all of the treatment and everything, the last result, they were offered an HIV test, and by that time their T cells were under 200. I'm asking that we support routine testing in all medical situations, all doctor's office and emergency rooms, so that we can, testing is prevention and we can prevent HIV.
Phyllis Malone, Trevor Pearson, Malone, Pearson, and Dr. Spalding to come forward in that order, please.
Hey y'all, my name is Phyllis Malone. I work for Sister Love as an HIV prevention specialist. I can tell you just a little slight bit. Okay, I asked for the HIV test because working in the medical field, I had some type of symptoms as one of my patients. So I was at Kaiser, and Kaiser, I had to ask them for the test. And I found out the doctor told me that if I hadn't asked for the test, he would not have done the test on me. Thank you.
I give her a back.
Okay.
She can have back.
Give us your name.
Hi, I'm standing in for Dr. Ann Spalding from the Center of Health for Incarcerated Persons at Emory University.
Okay.
Awesome, thank you. I'm Tiffany Lemon, by the way, and I'm a Master's of Public Health candidate at Emory. So I'm going to talk to you today about a public health intervention that could take as little as 1 minute. Right now, over the course of their lifetime, 1 in 4 African American men living with HIV will go through the prison system. Although only 33% of the Georgia population is black, our prison populations are 60% black. So what this translates to is that incarceration settings provide a unique public health opportunity to identify cases of HIV. The CDC, like it has been said before, recommends routine HIV testing in public settings, yet Georgia and a few other states are lagging behind that within jails. Right now, if testing is being implemented in jails, it's usually conventional testing, and conventional testing lasts, it takes a few days for the test results to come back. The problem with this is that most detainees pass through the jail system within only 2 days. So by the time the test results come back from the conventional testing, the inmate has usually been released from jail and can sometimes be undetectable, or you can't find the person. And so right now we suggest, or we found that rapid HIV testing, which can take as little as 1 minute to 20 minutes to complete, would be a perfect match for HIV testing in the jail environment. Right now, all jail detainees, once they come into jail, they have to do a nurse evaluation, which conveniently takes about 20 minutes to complete. If inmates are offered this HIV testing in enrollment, which 80% of inmates do opt to take the testing, it's not coercive, so they aren't required to test, but it is offered, and 80% accept. We actually implemented this program, our research group, at the Fulton County Jail in the past few years with funding from the CDC and other corporate sponsors. And in only 1 year, we've identified 89 new cases of HIV. And within Fulton County, this constituted about 15 to 17% of the entire cases identified over the course of the entire year. So what this is telling us is that testing in prisons, specifically jails, is very important to catching new cases of HIV. And out of that 89 new cases that we identified, 85% of the new cases were African American, and out of the 90% of the cases were men. And out of the 90% of the cases that were men, over 30% were men who have identified as men who have sex with men. So not only is HIV testing in jails a unique public health opportunity to catch new cases. It's a unique opportunity to catch new cases of HIV in the Black community and also in the Black MSM community as well. And so what we've come to you today and to present to you is a unique opportunity that we hope that will be taken advantage of with funding from the state and not relying on funding from academic programs that could be cut short. We want to see this continue. We want to see this sustained. Right now, it's at the Fulton County Jail. There's opportunities at DeKalb County and the other major jails in the Atlanta metropolitan area. So we just hope that the funding allocations will reflect the importance and just the identification of this as a really opportunistic time to catch new infections of HIV. Thank you.
I will say that state appropriations can be problematic too. So, in addition to academic allocations, but I appreciate your comment. You may remember the last time we were together a few months ago. Many of you were at the Black Caucus forum on HIV, on the HIV epidemic. I forget the exact World AIDS Day, on World AIDS Day. I said then, and I'm going to repeat, that a big part of this is what? Because several people in their policy recommendations have talked about what? Money, dollars, and appropriations. I'm a member of the Appropriations Committee. Are you a member of the Appropriations Committee, Madam Chair? So when we conclude after the next two speakers, we're going to have something to say about that. Trevor Person.
Thank you, Senator.
Thank you. Trevor Person. And then the last person who's going to speak is Walter Tisdale. Is Walter Tisdale here? Is Walter Tisdale here? Then Mr. Person, you're going to be the last person to present.
Madam Chair, Senator Ford, thank you for the opportunity. My name is Trevor Pearson. I serve as the first Vice Chair of the Metropolitan Atlanta Health Services Planning Council, which is commonly known as the Ryan-White Planning Council. I also serve as a patient navigator as well as a pre-exposure prophylaxis specialist. I'd like to present you 5 of those points of the 10 points that you talked about. I'm not going to give you the whole presentation. I'd like to list first the provision of reasonably priced, stable, long-term housing. Second, medical coverage for low-income residents. Third, a quicker approval of the state's AIDS Drug Assistance Program, commonly known as ADA. And fourth, sexual education to our children that includes discussions beyond abstinence. And the fifth, the provision of PrEP to HIV-negative individuals. I know a lot of people have talked about those areas, but I can tell you in New York City and New York State, housing was made available 25 years ago. We are really behind, and I think that I've looked at a number of areas in New York, particularly Bailey House. There, the way in which they looked at housing in terms of working with the government, private and non-profit partnerships, they were able to provide housing that we could do if we put our minds to it. I would like to particularly mention that a recent survey of Ryan-White funded programs showed that the time the state took to approve ADAP applications ranged from 6 weeks to sometimes more than 8 weeks. What the result of this was that clients took a longer time to start taking their medications. They missed their doses of medications. Clients became ill. The patients could have become resistant to medications. Worst of all, they might have been able to pass on the virus to their partners. And I think when we talk about funding, not only is we know that there's funding available, but we have to ensure that processes that are in place ensure that things happen faster. I'd like to thank you for the opportunity to say this one thing. As a former teacher, I can tell parents that they think that they are their children's they think that they're children's greatest influence, but their greatest influence are their peers. They talk among themselves and they talk about issues. We have to change the way we talk about sex in this country. As an immigrant, I can say that one of the things that I find strange is when we talk about our bodies, how people get very upset and concerned. But unless we talk about our bodies, we're going to continue getting what we have right now, and that's the continuation of HIV and AIDS. Thank you very much for your opportunity.
Yes, I have a couple of questions. So this needs to go back to William Lyons and Michelle Allen. I want to ask you all a question in regards to something I heard throughout the conversation now and before. We talked about EPT, which is, I think, the expedited patient therapy. And some states have been doing this as far as giving prescriptions to people to take back to their partners. I want to know from you all what, because I was mentioning this to a few legislators and they were like, well, how do you prescribe medicine to people that you haven't, doctors prescribe medicine to people they have not seen, and what would be the liability? And then we got into a little debate of, well, what would we do if people continue to be infected with STDs and the rate in Georgia is so high? So I just kind of want to get a feel for what states are doing this and what can we use to further this conversation on EPT, expedited.
Okay, Alabama would be the best example to use to compare against Georgia, because things that we have in common with them are not just high disease rates, but also how the pharmacy boards are set up. The first thing is public health often provides what people call epi-treat. So based on exposure, clients are routinely, and this is a common practice everywhere, if someone is exposed to chlamydia, you can treat their partner based on their exposure. What we're proposing in Georgia to bring a medical encounter is that they present to a pharmacist or at least a nurse, so that it's not about allergies or a reaction. Because people, that is the concern for people who have not implemented. Some of the states that have it on the books, quite frankly, they're not using it. And I would like to see us have it on the books for public and private to use at the same time. Those 60,000 cases, the bulk of chlamydia cases are actually coming from our private partners. So if we strengthen laws around disease reporting, we know we can find out better information of who they are and how to follow up with them. Doctors routinely do it with other infections like trich. They feel like this is lesser. Gonorrhea is not a part of our proposal because we're concerned about resistance, and obviously we don't want to do anything that could potentially further resistance. The laws that have us in between in the states, it doesn't say no, it doesn't say yes. Right now, it doesn't appear that it would be any kind of medical liability on the practitioner because they in fact did not see the patient. And we wanted to have a pilot so we can control, and we just wouldn't give somebody 20 packets of a drug to not know that they were doing the appropriate thing with it. So we know that it's tough, and to be honest with you, it's not a lot of good data because it's very new on the questions that people have, but we propose that if we could at least do a pilot or get it on the book somehow, then we could look at the data that we have in our own state.
Thank you.
Okay, first of all, I want to thank those persons who spoke about their status for the first time. Several people stepped to the microphone and said this, I'm nervous, this is the first time I've spoken publicly about myself. And for those people, I have a deep appreciation for and just want to thank you. In effect, you're saying you have a responsibility to do what? Help both other people. So that's a great service you do, and I don't want to let this go by without having said that. Two, the chair has consented to allow me to propose something. Because this is wonderful information, very important, something she is committed to. What I am going to propose to the GLBC is that we put together a 10-point, maybe 15-point, but 10-point, 15-point position paper for the GLBC on the HIV epidemic in Georgia. All right? Now, we're going to take the information that you presented to us today, not just the professionals, but the activists and organizers have presented to us today. But beyond today, we're going to need you to do what? To be available so that we can say, well, what about this? What about that? Because in 2 hours, I mean, there's 200 hours worth of knowledge in this room. We could do this every day for the next 6 months and still, you know, be sharing knowledge. But I would ask y'all to be available. I know, Devin, you're available. And because at some point, the GLBC is going to have to do what? Raise the profile and be seen as what? Point on policy on this issue. All right? How's that sound?
Great.
Are we together?
Yes.
We're not going to take any more questions.
No, maybe just not a question, but a statement. I work over at Grady as a chaplain there, and I think if you talk about doing that piece, I think it's important within that piece that you do to address, someone said that earlier, to address the religious community about that too.
Yeah.
I think somewhere in that needs to be stated to bring
Okay,
that.
that's fine. And what I want to do is give you my contact information, my email address, senator4@gmail, very easy, senator4@gmail. Yeah, FORT, senator4@gmail. My Twitter, @senator4, and my Facebook is Senator Vincent Ford. And, you know, Danica and other staff are here available, you know, to get information. If you have information that you committed to sending to us, please do what? Please send it, all right? So that we can begin to formulate. I have a couple ideas, but keep in mind, my thinking is that, you know, this is policy development. So there has to be consensus, because everybody ain't going, you know, some people are going to say, why you leave this off? Or why you put this on? And we have to be what? You know, mature enough to understand that it is a consensus going forward. So I'm gonna present that to the chair of the GLBC, because it's time to what? Get busy. All right? So in the spirit of that kind of approach, I know I have, I'm gonna turn over to the chair to close. I do this in memory of those who have gone before us. Because everybody in this room, on that side of the ledger, on this side of the ledger, knows someone who has left us. My cousin, Dana, is on my mind and in my heart, even as we speak. He's not here with us, but we can do what? Make sure that he's not forgotten through the action that we take, who we stand with what we stand for. So thank you for being here. God bless you. And I'll let the chair close things out.
Thank you so much, Senator Ford, for moderating our panel today. And thank all of you for coming out, because this is not an easy conversation, but it's a necessary one. And so we have to do something. We can't keep giving lip service, or some of us in the legislature, we can't turn a blind eye, because when our brothers and sisters are suffering, we all suffer. And so we have to remember that and be mindful of why we serve in the first place. And I'm just glad that you all are here. I want to thank Devin Ward, who has been carrying this, you know, to the Black Caucus, did not give up, was very clear in what he wanted to see accomplished, wanted to bring the community together, and I'm grateful for that. Thank you, Danica Key, our executive director, who works with the Black Caucus, who has worked with Devin for the last 2 years with the World AIDS Day, and again with this particular symposium. Thank you, Danica. And so if you all don't have the contact information for the Black Caucus office, it is 404-651-5569. Exactly. The email is GABlackCaucus@aim.com or AOL.com. So it's GABlackCaucus@aim or AOL.com. Either one you want to use. So at aim.com or at AOL.com. Okay? Then we want to thank Dory and DeAndre for sitting over here on the side. It wasn't I forgot DeAndre's name. I was trying to think if I was going to say your last name and your last name, and I decided to say your first name. So thank you all for taking notes because we need all these notes. We want to thank Clive for putting this on videotape because what we'll do, every time we have a symposium, I don't know if you all can say what we do. We take the entire symposium and then we upload it. And then what we do is we show the rest of the Black Caucus, we show other legislators, so the entire thing has been filmed today, so you will see it again because we needed to make sure that we don't forget anything. Because sometimes you can be talking and you won't write things down and you forget. So this is why we filmed the entire hearing today. And then know for sure that Black Caucus members have watched this. So like when you saw me leave out earlier, I had to go run and vote on a bill. That was, so I had to go to another committee and run because sometimes they try to pull tricks at this place. And so, Representative Sandra Scott, who was sitting there, she left first. She texted me up here and said, "Girl, they about to vote on this bill and they know you're not here. We need the number." So that's why when you see me move really quick, I got there, I moved really quick to go vote, and then I came back. So I hate that I didn't get to hear you speak from Sister Love, but I need to get in there. Real quick, so I'm going to watch it on video. But I just want to say I'm glad that Senator Ford has agreed to kind of take some of this on. I don't know if I volunteered him. I kind of, you volunteered. You work together, because this is what happens. This is important. This is some serious business. And we can't keep playing with this because our lives are at stake. This is real stuff. And so I don't just come as a legislator, I'm also an ordained minister in the AME Church, and so we have got to make sure that not only the legislators deal with it, the Black church has got to deal with this situation. One of the things that I've done is I've told, the members of the church, the different denominations, every time they come to the Capitol, we've got to deal holistically with the Black community. And if it means we're dealing with whether it's healthcare, education, for me, having HIV/AIDS or STD, that is a healthcare issue. And it's not just a healthcare issue, it's a quality of life issue because it affects so many of us, but not directly, indirectly. And so if we don't do something about it, who will? So that's why I'm glad you're here, because you're the first group. This is the group. You are the ones who are going to make a difference. We are the ones that we were waiting for. We are the ones. And so, since we're the ones, Senator Ford is going to sit down. He like, if he don't like it, he's going to like it. He's going to sit down and get this together because we want to make sure that Georgia is the model. Because since we have the highest prevalence, the numbers, Georgia's going to be the model. And then I also serve as a national officer for the National Black Caucus of State Legislators. We just had our executive board meeting 2 days ago in D.C. and I already told them that we were having this. And so they said, whatever comes out of that, and y'all put it together, we'll see y'all doing this right here. This room is the room that's going to make a difference for Black people across the country. So, that being said, all hearts and minds clear. Thank you all again for coming, each and every one of you, for all of your testimonies, for all of the information that has been shared. We will do a follow-up because I don't believe in not having follow-up. So if you have the information, make sure you get it to any of those 3 people that I named, get it to Senator Ford, because we need to have this done and presented before we leave session. So.
And I would say, since you are a minister yourself for the church, that we don't talk about homophobic, make sure particularly the Black churches that they know that it's not an issue of homophobia. And it comes up, I have patients all the time that can't come out, that are afraid to get tested because they don't want to be ostracized. And so, thank you.
Thank you. And that's something we're going to have to deal with collectively. So that being said, thank you all again for coming out. We appreciate all of you and have a safe travels and journeys back to your destination. Thank you.